So the first one is acne vulgaris, which is simply acne. Papules, nodules, or cysts can appear on the face, neck, shoulders, or back due to clogged oil glands. 90% of the time it affects adolescents. During adolescence, androgen increases, which increases sebum production, which then combines with keratin to form a plug, leading to acne formation. Non-pharmacological treatments include using cleansing agents, eating well, and stress management. Keratolytics such as benzoyl peroxide can treat mild acne by loosening up the outer layer of the epidermis. Retin A and Differin are commonly used to treat mild to moderate acne. Moderate acne may also require topical erythromycin or clindamycin. And severe acne requires systemic drugs such as oral antibiotics, and the drug of choice is tetracycline. A major side effect of tetracycline, however, is photosensitivity and can also have negative effects on fetuses. We should also teach patients taking tetracycline to avoid drinking milk or taking antacids at the same time of taking the medication. Finally, for severe cystic acne, Accutane may be prescribed. Accutane is a derivative of vitamin A and is usually taken for 4 to 6 months. It can have severe adverse reactions, including nosebleeds, pruritus, and inflammation of the eyes and lips. Patients should be taught to report muscle weakness because that may indicate serious muscle damage. And of course, Accutane must not be used during pregnancy. Before treatment can even begin, 2 negative pregnancy tests are required. And all throughout therapy, 2 methods of contraception should be used and continued 1 month after treatment stops. Psoriasis is a chronic skin disorder that affects 1 to 2% of the U.S. population. The onset usually occurs before the age of 30, but may develop as early as 10 years of age. It's characterized by erythematous papules and plaques covered with silvery scales. It can appear on the scalp, elbows, palm of hands, knees, and on the soles of feet. The plaques are caused by an accelerated amount of epidermal cellular growth, up to 5 times the normal amount. Psoriasis can be easily controlled, but periods of remission and exacerbation are common. And there are a lot of medications out there, but a common topical medication use is called anthralin. It's important to teach patients that anthralin can stain clothing, skin, and hair. It can also cause skin and eye inflammation. Coal tar, which can be found in some shampoos, isn't commonly used anymore due to its smelly odor and its tendency to cause a burning sensation on the scalp. For moderate psoriasis, the topical Dovanex can be used, which slows the abnormally rapid growth. However, Dovanex can cause serious hypercalciuria and hypercalcemia. Severe psoriasis can be treated with an anti-cancer drug known as methotrexate, which slows the growth but can also cause the skin to peel. It can cause anemia, leukopenia, alopecia, cystitis, and more. Ultraviolet A can also be used to suppress cell division and may be used in combination with other drugs. And finally, there are a bunch of biologic drugs that can be used, but they tend to be very, very expensive. But what's nice about them is that they tend to have fewer side effects. Then there's Bruca vulgaris, which is also known as a common wart. Our book describes warts as hard and horny nodules that can appear anywhere on the body. Warts can be benign or they can be precursors to cancerous lesions, especially those found in the genital area. Warts can be removed by freezing, electrodesiccation, or surgical excision. Drugs used to remove warts include salicylic acid, podophyllum resin, and cantharidin. Podophyllum resin should not be taken during pregnancy, and it is also important to know that it's more effective at treating venereal warts rather than common warts. Both salicylic acid and podophyllum resin are absorbed into systemic circulation, which poses a risk for toxicity. Signs and symptoms of toxicity include peripheral neuropathy, blood dyscrasias, and even kidney impairment if the area being treated is large enough. Cantharidin removes warts by forming a blister under the wart and cutting off the blood supply. An example of how this all works is that the cream would be applied, allowed to dry, and covered with a non-porous tape for 24 hours. If the wart isn't completely gone, the procedure can be repeated in 1 to 2 weeks. As you may have noticed, there are a lot of over-the-counter drugs marketed to remove warts, but some of them are questionable. The book does mention that if you had to pick one, try to pick one that contains salicylic acid because it's more likely to be effective. Drug-induced dermatitis is a reaction to drug therapy that causes skin lesions. The lesions can be a simple rash, hives, papules, or it can be a life-threatening skin lesion such as erythema multiforme. Erythema multiforme is characterized by red blisters over a large portion of the body. Then there's Stevens-Johnson syndrome, which consists of large blisters in the oral and anogenital mucosa, pharynx, eyes, and viscera. Another adverse reaction is toxic epidermal necrolysis, which is a widespread detachment of the epidermis from underlying skin layers. This condition is often linked to sulfa antibiotics. There are certain drugs that may also cause lupus-like symptoms, and if lupus-like symptoms appear, the drug should be immediately discontinued. Drugs that could cause this include hydralazine hydrochloride, isoniazid, anticonvulsants, and antidysrhythmics. And finally, certain antibacterial and anticonvulsants can cause something called exfoliative dermatitis, which is erythema of the skin, itching, scaling, and loss of body hair. Next is contact dermatitis, which is also known as exogenous dermatitis. It's caused by either chemicals or plant irritation. Examples of chemical irritants are cosmetics, cleaning products, clothing, dyes, or topical drugs. Examples of plant irritants include poison ivy, oak, or sumac. Prevention methods include obviously avoiding the irritants, wearing protective clothing, and immediately cleansing the skin after contact. Treatment consists of applying wet dressings containing Burow's solution, which is aluminum acetate, or calamine lotion that contains zinc oxide, or calcium hydroxide solutions, or glycerin. Calamine lotion has diphenhydramine in it and it is primarily used for plant irritants. If the itching persists, Benadryl is used. Interestingly, topical Benadryl is not recommended because, if used, it increases the risk for an allergic reaction to systemic Benadryl. Other helpful treatments include oatmeal baths, glucocorticoid ointments such as dexamethasone, hydrocortisone cream, or Medrol. Long-term use of a topical glucocorticoid can lead to thinning of the skin and rupture of small vessels. Impetigo is a common staph infection of the skin, usually infecting children between the ages of 2 to 5 years old. Topical agents are used to treat mild to moderate infections, whereas oral antibiotics are given if the infection is severe, if there are multiple lesions, or if topical therapy is ineffective. The two drugs of choice are Bactroban and Altobox. Hair loss and baldness occurs when the hair shaft is lost and the hair follicle can no longer grow back. This condition is also known as male pattern baldness or alopecia. Certain conditions such as pregnancy and myxedema and cancer therapies can contribute to temporary hair loss. Men and women can be treated with Rogaine. Rogaine causes vasodilation, increasing blood flow, which stimulates hair follicle growth. However, if the drug is stopped, hair loss will reoccur within 3 to 4 months. Rogaine is minimally absorbed past the skin, so adverse reactions rarely occur, but sometimes people will experience headaches or a slight decrease in systolic blood pressure. Another medication used to treat hair loss in men is finasteride. It's also used to treat BPH. Finasteride is effective in growing hair in 50% of men and is less effective in older men. Sunscreens can be divided into 2 categories, chemical and physical. Chemical sunscreens absorb UV radiation, whereas physical sunscreens scatter UV radiation and prevent skin penetration. Out of the 126 FDA-approved sunscreens, most are chemical types. Examples of physical sunscreens include titanium oxide and zinc oxide, which are usually only applied to the nose and ears. Sunscreens protect against sunburn photosensitivity but don't guard against melanoma or basal cell carcinomas. Sunscreens with an SPF greater than 15 are most recommended. If insect repellent and sunscreens are used together, make sure to apply the sunscreen last. And finally, side effects of sunscreen include contact dermatitis and photosensitivity. These are more common with sunscreens that contain patamate derivatives. For first-degree burns or minor burns, cold, wet compresses can be applied. This constricts blood vessels and decreases swelling. For minor burns, polysporin can also be used. For chemical burns, clothes should be removed immediately and the skin should be thoroughly flushed with water. Second and third degree burns obviously require immediate medical attention at a burn center or hospital. While there, IV therapy will begin immediately and pain meds will be given. Burned areas are cleansed with sterile saline and an antiseptic solution such as betadine. Always remember to check if the patient is allergic to iodine or seafood before using betadine. In addition, broad-spectrum topical antibacterials may also be applied to prevent infection. These include sulfamylin, silvadene, silver nitrate solutions, or furacin. Sulfamylin is applied multiple times a day after the wound is cleansed and debrided. It's normal for the person to report a burning sensation. The medication is absorbed through the skin, metabolized in the liver, and excreted in the urine, so it's important to monitor renal function. Sulfamylin can cause acid-base imbalances, such as metabolic acidosis or respiratory alkalosis. It also has a mild diuretic effect. If a patient being treated with sulfamylin or mefenamide acetate if the respirations become rapid, labored, or shallow, the cream should be discontinued for a few days until the acid-base imbalance is restored. The last common topical for burns is silvadene. It's used to prevent and treat sepsis in second and third degree burns. And unlike the previous medication, it does not cause acid-base imbalances. Silvadene is contraindicated in pregnant women at or near the end of their pregnancy. And side effects and adverse reactions may include skin discoloration, burning sensations, rashes, erythema multiforme, skin necrosis, and leukopenia. And that is all. Thanks for listening. Bye!